Good morning, everyone. This is Jill Hennis from the Minnesota Department of Health. I'm very happy to welcome you here to this short and powerful presentation on our evaluation that we did for the MCV expansion grant. This evaluation ended quite a while ago, so if you're thinking this is the new one, you're in the wrong place. This is the one where we were evaluating the effectiveness of our support to local MCV sites in terms of reflective practice. So this was the work of the infant mental health consultants and the mentoring of the infant mental health consultants and all those things. So we had so many people participate in this evaluation, some of them very many times. And we are just so grateful for all the input and time that home visitors and supervisors and directors committed to this project. I think we have some important results to share, and just very excited to share it with you. A couple of quick just announcements. We do have the capacity to mute your lines, so we don't have to ask you to do it, right?
Correct.
Anne is all-powerful. She is muting your lines, so don't worry about sneezing or anything. We will have the executive summary and the full evaluation report that SEED created for us available through Tuesday Topics next week. We sent it out a while back, but we'll send it again in case you're interested in further pleasurable reading. And I think that's it. I would like to introduce Ann Bailey, who has been just a stalwart and very creative participant in our evaluation team. She is a employee, what do we call you?
Oh, my technical title is Research Fellow.
Research Fellow at the University of Minnesota Center for Early Education and Development. So I'm going to turn it over to Ann, and questions, we were thinking if you have questions that come up during the presentation, just put them in the chat, and then we'll try to address them. If they fit right in, we'll address them at the time, because Ann has a young mind and she can do those kinds of things. And then some other questions we might leave till the end and address them. And we will be asking for questions at the very end.
Absolutely.
Okay. Great.
So,
thank you,
Jill. Good morning, everybody. It's good to see your names. I can see who's on the WebEx, so it's good to see names that I've talked to either by interview or I've looked at your name because I've looked at your data. So I'm excited to be here this morning with you. And as Jill said, please, if you're on WebEx, feel free to use the chat function to send me any notes about if you can't hear me or if you want to ask questions as I go along. But we will absolutely leave time at the end of near about 10:15 for those of you who are not on WebEx to, and anybody to ask questions at that time. So feel free to use the functions of WebEx as we go, and we'll get started. So as Jill mentioned, we were looking at does the infrastructure of that is part of MCV here in Minnesota, what's its effectiveness? How does it support the use of reflective supervision within the MCV program? So this money, we first have to acknowledge where the money came from because that's a very important part of how this work got done, including the evaluation. So we're grateful to federal dollars for that. But I want to spend more time acknowledging all of you and all of your colleagues and your supervisees, the supervisors, the administrators, the infant mental health consultants, really my colleagues Christopher Watson, Karen Storm, and I could not be more grateful for the time and the energy that you spent completing surveys, for many of you 11 times, and for some of you 3 times over 18 months, and then the interviews. At the end of this project, we did about 120 interviews. So, and each one took almost an hour. So we really, really appreciate all the time and energy you spent towards this. The data that I'm going to share with you today would not have been possible without your efforts. So we're grateful and thank you for that. So here are some questions that I'll have you think about as I go through this PowerPoint. We will be sending out the PowerPoint too, so those of you who are unable to see the slides today, you will see them, you will get a copy of them next week. So, and most of you hopefully have my contact information too. I can put that in the chat function. So if you have any specific questions of the data that you would like to ask me at any point in time, I'm still at the same email address, same phone number, so please feel free to do that. But here are some of the questions we're going to talk about, just reflective practice and some of the underlying assumptions. What's the MICV model? What are the specific findings that we found from this evaluation? And then sort of what's next? What will come of this? So I'm not going to preach to the choir, and I'm not a slide reader. You have the slides in front of you, but reflective practice, I think you know what it is. I suppose I should read it for those of you who are not on the slide, on WebEx, but what is reflective practice? It's professional development, and that's really at its core. It is a way for people to look at observable behaviors within interactions between supervisors and supervisees. So, sorry? And groups, yes. So here's some research information on why we use, why would you use reflective practice? So there are theories and some data to support the fact that, or the idea that reflective practice improves intervention efficacy, staff morale, and inevitably child outcomes, child and family outcomes. There is some research that also supports the idea that reflective practice improves self-awareness, whether it's the supervisor or the supervisee, the practitioner, reflective functioning, different perspective taking, and problem solving. So I'm taking it back. I am going to read some slides because I realize many of you are not on WebEx. So the next slide has basically the structure that exists within Minnesota in terms of how reflective supervision is used within the MICV program. So there are 19 different public health agencies across the state. There are mentors at the Department of Health that provide ongoing training, reflective practice to the infant mental health consultants, and support to other public health agency staff. There are infant mental health consultants. Some work with multiple agencies. They help support the case consultation time and often provide individual reflective supervision to MICV supervisors. Then MICV supervisors provide the reflective supervision to the home visitors and share case consultation leadership and responsibilities with the infant mental health consultant. And then the home visitors who do the home visits with the families who are often facing multiple stressors and provide ongoing support to those parents and children who may be deemed at risk. So the evaluation went about 18 months. We got off to a little bit of a slow start, but we really kicked it into high gear in the last year. So it was 18 months long. We had two main research questions or studies, the process and the impact study, and I'll go into those in a minute. We interviewed, as I said, over those 18 months, we interviewed supervisors, home visitors, the MDH mentors, and the infant mental health consultants more, often 2 to 3 times. The home visitors were the only ones that we interviewed once, and that was at the end of the evaluation. We, along with MDH staff, developed what we call the SEED survey, which really looked at practitioners' attitudes, beliefs, knowledge about reflective practice. And then we also had home visitors and supervisors complete 3 different measures, although it was provided in one survey, online survey. So we looked at the Kentucky Inventory of Mindfulness. So those of you who are online that took these surveys, you'll remember that that's the one that asked questions about, sometimes odd questions about, I feel the water when I'm in the shower. I feel the air move through when I'm walking. Or, so just paying attention to how mindful you are. There was the Maslow burnout inventory, which I'm going to talk quite a bit about later, but that was a 22-question inventory about burnout. And then the Working Alliance inventory measures the relationship between relationship between the supervisor and the supervisee. It was initially used with therapists and clients, and with permission from the author, we changed some of the wording to help us use it with this program. So again, if you have any questions, feel free to use the chat function. So the process study we grouped the 19 different sites into 2 groups. So we had group 1, we considered those that were relatively new sites to reflective practice and reflective supervision, and we were able to determine that based on the application that the 19 sites submitted. The group 2, which was, so there were 8 sites in group 1. Group 2 had 11 sites, and those were the sites that said, no, we've been doing reflective supervision for some time. Some said, we've been doing reflective supervision a very long time. It's embedded in our culture. So the group 2 were those that had been doing reflective supervision for at least some time, up to a long time. So the process study was for group 2. We looked at the relationships between reflective practice using mindfulness, burnout, and the working alliance and the therapeutic alliance between the supervisor and the home visitor. We looked at understanding perceptions about the intervention, which was training on reflective supervision, and then we wanted to use that information to inform efforts to improve professional development. To on the slide it says EBHV, I don't like acronyms, but evidence-based home visiting programs. So the impact study was specific for those sites that were in group 1, those 8 sites that said they were new to reflective supervision. And what we wanted to see was their impact of getting training on reflective supervision, on skills and knowledge and attitudes and beliefs about reflective supervision. So we designed a study, we call it quasi-experimental, because we weren't going to have some groups get the intervention and some groups not. Everybody got the intervention, but we looked for change over time. So those that were in the impact study took those 3 measures, the Working Alliance, the Kentucky Inventory, and the Maslow Burnout Inventory, 11 times over the course of 18 months. So they took them 4 times, once a month for 4 months in a row, then got training on reflective practice and infant mental health, then took them 7 more times every other month across the next 14 months. So every other month, 7 more times. So we looked to see if there was any change in knowledge, attitudes, beliefs about reflective supervision over time. So we really took a system-wide approach. We were looking at how does this infrastructure work, how does the support, the training, how does that all help implement with fidelity the practice of reflective supervision. So we looked at what the state supplies or the state support, including dollars for the infant mental health consultant that you all really appreciated, and we looked at beliefs and attitudes towards reflective practice, and we asked that of everybody in the system. So we asked agency directors, the mentors, supervisors, home visitors, and we asked specific knowledge and skill questions, like I said, of everybody to see what people know, who knows kind of what information at what time, and compare that over time. What we were hoping to see is that as a result of this infrastructure and the support provided, that we would see a reduction in burnout, and that you all would feel better and more efficacious in your work. I didn't make that word up. Efficacious is a word. All right, so there were 5 research questions. Many of them have sub-bullets. So we're going to go through them, each one, some more than others because of the data that we found, the findings that we had. So I'll go through all research questions and I'll come back to them, and then we'll go through them individually. But again, please feel free to use the chat function to ask any questions that you'd like along the way, because that really will add to the discussion. So our first very basic research question was, are state support sufficient for implementing reflective practice in local programs? Do you have what you need to really implement with fidelity reflective practice? So that's what we wanted to know. The research question 2 had 2 parts, 2A and 2B. So 2A looked at, do supervisors who participate in reflective practice with state mentors gain new knowledge and skills in reflective practice? 2B asked the same question, but of home visitors. Are they gaining new knowledge and skills by participating in reflective practice? Question 3 had 3 parts. So question 3 was 3A was, do program directors change their expression of support for reflective practice throughout the course of participating in the grant activities? 3B was, do supervisors report positive changes in their attitudes and beliefs about reflective practice? And 3C looked at what home visitors, do they change their, or report positive change in their beliefs and attitudes about reflective practice? Question 4 only had 1 question. So, do home visitors who participate in reflective practice, do they report using reflective practice with, in their work with families? And then question 5 had 2 parts. Do supervisors report less burnout and increased competence? And then question 5B was, do home visitors report less burnout and increased competence in your work? So we did answer all these questions, and as I mentioned, I'll go through each one. Question 1, I'm not going to go through too much because we had a whole lot of data that said the same thing, so you'll see. So again, are state support sufficient for implementing reflective practice in local programs? And what we heard was, yes, sort of. That was, I almost put that in the slide, but I didn't, to some extent. So when we asked this question, whether it was in surveys or interviews, and the interviews were very rich in detail, what we heard was about half said, yep, I got enough training between the evidence-based models, nurse-family partnership, Healthy Families America, and what I get from the state, that's enough. And others said, nope, not enough. It was too little, I need more, or it didn't come when I need it. It either came too late, and I was already expected to be implementing reflective practice. So about half and half. Administrators, rightfully so, are concerned about ongoing funding for keeping reflective practice and for accessing training, but they very much said, we are committed to this. So there was no change in, when we interviewed them at the beginning, they said, we're committed to it, and at the end, they said, we're committed to it. And supervisors said a number of different things. They said, we need some standard foundational information about reflective practice that we can use at any point in time. So as we have turnover in staff, we need that foundational information and refresher courses for those who have maybe been there a while and need to hear the foundational information again. The supervisors very clearly said, we would like our own reflective practice group of just supervisors. So, and that came out over and over again in a number of questions we asked. Some of them that are located in the metro have that already. It was really a lot of, many of the supervisors that are not located in the metropolitan area said, we would like to be a part of a group just for supervisors that on reflective practice. The supervisors were very positive about the support that they were getting from MDH staff. They also said, we want reflective practice for all of our public health nurses. So whether you work in WIC or MICV or any other program, they thought everybody deserves to have reflective practice, and they want to know that it's going to stay, that it's not a flash in the pan, that it's something that we're going to invest in for the long haul. So research question 2, again, this is 2 parts, but I combined the data. We had 2 questions, do supervisors gain new knowledge and skills, and then do home visitors gain new knowledge and skills, and I'm going to present those data together. So I should say right at the beginning too, we got a lot of quantitative data from the surveys that frankly there weren't a ton of findings over time from the quantitative data. And the primary reason we think is that reflective practice, like any other intervention, takes a long time to really implement with fidelity. And so to expect to see massive amounts of change over 18 months is very unrealistic. I think we felt very confident that if this evaluation had gone on maybe another 18 months, we would have seen greater changes in the quantitative data. So you will see I'm presenting a lot of the qualitative data, the data that we got from the interviews, because that data was so rich and so full of concrete specific examples and major themes that emerged from those data. So you'll see I'll present mainly the qualitative data as we go along and quantitative where we did have findings. So when we asked people about have you learned new knowledge and skills, several themes came about. First and foremost was they said, yes, I learned to pause and reflect. I don't need to solve the problem immediately. I learned to take a breath and just listen. So for those of you who are not on WebEx, I have quotes. I'm not going to read each quote because that would take a really long time. So, but there, when you get the PowerPoint, you'll see I have quotes. Anything in italics on the PowerPoint are quotes that we got from you who participated in the interviews. Another theme was that it's very connected to pause and reflect is wondering and not fixing. So really thinking about what might be going on instead of how can I fix this for them. So, and people said that's challenging and it's hard to learn, and I continue to learn that, but I'm getting better at wondering rather than fixing. Another theme about gaining new knowledge and skills was we termed it going deeper because that's what you all said, is that instead of having a superficial look at what's going on with the family or what's going on with the home visitor or the supervisor, that you really took time to self-regulate, take a breath, and try to dig deeper into what might be going on. So keep bringing it back to the baby and the relationship between the parent and child. And I'll read one quote. It said, I'm digging deeper into maybe my own experiences and why I'm reacting the way I'm reacting, which we also heard quite a bit, is that related to self-regulation, that I'm bringing, as a home visitor or as a supervisor, I'm bringing something to the table too. And how is that impacting my relationship with the family or with my supervisor or the home visitor? Finally, keeping the baby in mind. People said this over and over again, that the new knowledge and skills that they've gained through reflective practice helps keep the baby and what's going on with what the baby is experiencing at the forefront. So I'm not seeing any questions yet, so you're doing well at listening. So research question 3, I did keep as 3A, 3B, and 3C, so you can see. So the first one asked about what do agency heads think about reflective practice, and has their support for it changed? And really, their support, as I mentioned, didn't change in that they said they fully supported it when we first asked them at the beginning of the evaluation, and they all were fully supporting it at the end as administrators' responsibilities. They were concerned about money and funding, especially the infant mental health consultant. But I thought there were 2 themes that came out of those interviews that were interesting to us as evaluators. And one is that the agency has really recognized that people have individual differences. So some take to reflective practice like a duck to water, and others may never warm up to it, and then there's all those in between. And so, agency administrators really recognized that it took different people, different speeds it took them different times to really adopt reflective practice skills and knowledge. They also recognized that that this is sort of in their minds, that they accepted it as, yes, this is part of the evidence-based practice, so we're doing it. So this is not a flash in the pan. This is not just a blow-by intervention. This is here to stay because it's part of the national models. Research question 3B looked at supervisors and whether or not they changed their attitudes and beliefs about reflective practice, and there were a number of themes here. First and foremost there was a lot of support for the intervention, for the use of reflective practice. Supervisors overwhelmingly said This helps the home visitors, it helps the family, and I believe in it. So that came out loudly and clearly. Supervisors also really focused on the support that reflective supervision provides to home visitors. So one of the quotes is, "It's a very supportive way of nurturing and professionally developing your staff." Like the administrators, the supervisors identified the theme of individual differences. They said clearly some find it easier to adopt and integrate into their practice, and others struggle more with integrating reflective practice into their work behavior. So, and frankly, some supervisors were concerned about that. How do I really help those that are struggling? How do I support them in learning these skills and using this in their practice? For those that, one of the things we heard clearly from supervisors, especially those of you in rural areas, were that reflective practice is made and reflective supervision is made much more difficult when you have to travel. So as much as you can use Skype or technology to talk to supervisees, that's not the same as sitting one-on-one in a room with that person, looking at their face and their facial expressions and feeling their body language. And so people identified that that was really an obstacle to doing reflective supervision well. So research question 3C looked at whether home visitors reported change in their attitudes and beliefs, and there were 3 initial themes, and then I'll go into some additional themes. So one of the things home visitors said right off the bat is that reflective practice, and these are my words, not necessarily theirs, but it's a little scary, because I don't know what it is. I'm being expected to do this, and especially if you come from a traditional supervisor-supervisee experience where you wouldn't necessarily tell your personal emotions, or your, maybe you're bringing your own experiences to the table, you wouldn't necessarily share that with your supervisor. So there was fear of the unknown expectations. What would happen during these sessions? Why am I being expected to share my emotions? That's not something I might be comfortable with or ready to deal with. And one of our favorite quotes was, "It's weird. That's weird." And we heard that over and over again. And similarly related to that is just hesitation and apprehension. It's too personal. This is work, and I have work, and then I have home, and this is things I would share at home, but not necessarily things I would share at work. But there was also, as much as there was hesitation and apprehension, there was also a level of excitement and enthusiasm about it. And one person in particular said, "I really wanted to be part of this program because I knew that reflective supervision was part of the work, and I wanted to work in an environment that used reflective supervision." So home visitors also said there were other themes in what they told us about the use, they're gaining new knowledge and skills around reflective practice. Just general positive expressions. People overwhelmingly said, "It's really good, and I use it in my work life, but I'm also using it in my home." So I know I spoke with one supervisor who said, "My family teases me about it because I often use the language of reflective practice with them. Like, I wonder if," and they've started to pick up on that. So I thought that was great. But there was also a lot of support from home visitors for the work, that they said, "It really helps me when I'm working with these families who often have so many life stressors going on. It gives me more patience, it gives me knowledge and insight, how I might help them." I love the quote, "It's more about excellence in our practice." So there was a lot of positive affirmations about what home visitors had learned, because new skills they had learned because of the use of reflective practice and reflective supervision. And then finally, they said there was support for the home visitors themselves, saying that I really need this. This work is hard, and it takes a toll on my mental health, and so I need this as part of my job. It helps me not take home the stress or if there's negativity, that I can deal with that in the reflective supervision individual sessions or case conference, and that then I can leave it there. So these themes, the themes that I talked about with the home visitor, they were repeated by supervisors and administrators as well. So I just wanted to make that point. There was a lot of commonality among the administrators, infant mental health consultants, supervisors, and home visitors. When we interviewed all of you, it was refreshing, and frankly, I don't know that I personally expected as many of the similar themes that were shared. So it was, that really I think is a strength of the program, that people are recognizing the same pros and cons of the use of reflective supervision. So research question 4 was, do home visitors who participate in reflective practice, are they using this in their work with families? And my first bullet is absolutely yes. Every single one of the home visitors said, yes, I'm doing my best to use reflective practice in my work with families. So, and what they also said about this is reflective practice helps me slow down. That instead of focusing on, checklist of things I need to get done, it really just helps me focus on sitting down with that family, and wherever they are in their world on that time when I'm there, that's where I am with them, and being present. So that was very clear. Again, the theme of wondering. So the quote I have here is, this morning I had a mom who has a 1-year-old who was throwing tantrums and screaming when she didn't get what she wanted. I was able to use reflective practice. What do you think she's thinking? Why do you think she's acting that way? Rather than saying, well, here's what you need to do, or you need to do this. So, and again, this is one quote out of probably 30, 40 quotes that we could have used. So we cherry-picked quotes. But there were multiple quotes for each one of these themes that I'm sharing. Home visitors also said when they use reflective practice with families that it helps them not jump to solutions, that it really helps them with building relationships with the family, that they're sitting side by side, they're learning things with the family, and it really helps with compassion and not getting There's a new lingo in the world of burnout and home visiting about, there's a whole, not lingo, research line about compassion fatigue. And so what the data here showed to us is that the use of reflective practice really helps home visitors maintain a level of compassion for families. 2 more themes about what, again, related to whether home visitors use reflective practice with families. One is the persistence, that because they use reflective practice, they keep coming back. Families learned that this is going to be a stable relationship in their life, that you show up every week. So that's fantastic. And then just empowering families. So it helping them realize that they make decisions for their life and their families. They're the experts in their own world. And so that using reflective practice with them can really help support them feeling good about themselves and decisions that they make. Research question 5, here's where you'll see more. I'll show you some qualitative data, but we did have some quantitative data findings here, which I find very interesting. So we asked, do supervisors, this is 5A, and I kept this split out. So 5A asked about, do supervisors report less burnout because of the use of reflective practice? And again, a number of themes. The first one was providing a safe plan to express and contain feelings. It should say safe place. I'll change that. Yeah, I just realized that. So what they said was it helps me feel better about my work and not so burned out because I have this place where I can talk about my feelings, my frustrations, and get past where I'm at to maybe look for new solutions or look for new wonderings, if that's a word. And so that there's somebody, that you're in it together. There's a collaborative partner in this process. Supervisors also identified that what reflective practice does is provide a different perspective, not only for the home visitors, but also for themselves. That everybody's, as I said, everybody's bringing their own experiences and emotions to the table in this very difficult work life. And so the use of reflective practice can help provide a different perspective, maybe a new way of looking something that you hadn't thought of before. So supervisors said that was very helpful in terms of burnout. And then again, this is hopefully you remember seeing this theme before, not trying to fix something. That, and I think we heard this from a lot of supervisors and home visitors, and so this is not just me saying this, but that this is, part of nursing is fixing things, right? You have a problem, here's how you take care of it. You have an infection, you get an antibiotic. That there are ways of fixing things, and so in this work that reflective practice really helps you all figure out, I don't necessarily need to fix things. I need to figure out how to support this mother or this father, and these children or this child where they are at this moment. So, and research question 5B asks about home visitors and whether they reported less burnout as a result of reflective practice. I'll talk about the themes first. First was that you don't feel alone or don't feel that you're feeling supported by the use of reflective practice. I like this first quote. I think home visiting can be a lonely job some days, and so you feel supported when you have that dedicated time to talk about some of the challenges. And I think that came out especially true for those of you, again, who are in smaller agencies where you're doing a lot of traveling off by yourself most of the time, that it provides an opportunity to feel connected to your colleagues. A second theme was we used the word venting, and what home visitors said, venting or expressing and containing feelings in order to get to a different perspective. So that this is hard work, and then I need to share what's going on in that hard work in order to get past that and maybe think about a different perspective or a new way of looking at things. This was also one of our, whoever said this, after you said it, the person who did the interview came to me and said, I just heard the most interesting thing. And so the quote is, if I had no outlet for that and I just came home, and then I can understand why people would just end up quitting eventually, because you feel like you're soaking yourself in the miseries of human suffering. So reflective practice provides that outlet so that you're not feeling like you're soaking yourself in the miseries of human suffering. Home visitors also said that reflective practice, much like supervisors, provides a safe and trusting environment that you can say what you need to say about what's going on with your families and with you, and that there isn't a risk of somebody coming back and saying, well, that's not right, you're fired, that it's a safe place. And also another theme was personal accomplishment, that because home visitors are using reflective practice, it helps them feel better about the work that they're doing. One of the quotes is, to me, it makes my work meaningful and fascinating, to be honest. So I have goosebumps right now because, you all took the time to do these interviews. I cannot thank you enough. To be on the receiving end of this information was so touching and so enlightening, and we often, after doing interviews, Karen Storm and I would often sit, and we didn't say your names, we just said, I just did an interview and wow, I heard this, and can you believe this story? Because we did ask questions about, give us an example of when you used reflective practice with families, and we heard amazing stories of the work that home visitors are doing with very challenging situations that families find themselves in. So I'm going to talk about burnout a little bit in terms of just give a tiny bit of research, because in order to understand the quantitative findings, you should understand how burnout is measured. So we used the Maslow burnout inventory, and what Christina Maslow found was that burnout can really be broken into three parts. The first is exhaustion, that when she asked people in a number of different fields, not just nursing or home visiting or social services, teaching, law enforcement, a number of fields, she did a lot of research, that people reported just being emotionally exhausted emotionally exhausted, which in turn led to depersonalization, or putting distance between yourself and those to whom you are serving. So instead of looking at unique qualities in people, that the person who is depersonalizing generalizes and says, oh, that group of people, and starts putting distance between themselves and the group they are intending to serve, and that they feel they're not feeling good about their personal accomplishment in their work, or inefficacy is the word she used. So why do we care about burnout? Well, what we see with burnout, and what Maslow and her colleagues found too, is burnout leads to all sorts of things: job withdrawal, absenteeism, your intention to leave the job, lower productivity and effectiveness, a poor employee environment. And she used the term, it's contagious, that those staff who are burned out have negative effects on those around them. And so she used like I said, she used the term, it's contagious. And that it also spills over, if you're feeling burned out at work, that inevitably spills out into your home life. So as a reminder, the burnout inventory was 22 questions, and those 22 questions could be broken down into 3 subscales. So related to the research, she has 3 subscales on this inventory: emotional exhaustion, which measures feelings of being emotionally overextended and exhausted by one's work; depersonalization, which measures an unfeeling and impersonal response towards recipients of one's service, care, treatment, or instruction; and then personal accomplishment, which measures feelings of competence and successful achievement in one's work. So what we hope to see over the 18 months is a decrease on scores related to emotional exhaustion and depersonalization, and an increase on personal accomplishment. So what we found was that home visitors, there was a difference in home visitor emotional exhaustion responses by geography. So those home visitors that are working in rural areas reported a greater level of emotional exhaustion over the 18 months than did their metro home visitors, counterparts. So, and that, we can tie back to the qualitative data too that said that was an obstacle, is being out and alone and by yourself, and finding the time when you have to travel an hour to see a family, finding the time to do those individual reflective practice sessions. So that first bullet, this first finding, correlates with the qualitative data that we found. We also found that home visitors who had 1 or 2 years of experience of reflective practice reported greater changes in emotional exhaustion, so they reported greater levels of emotional exhaustion than did their peers who had had 3 to 5 years of practice or more. So those that are newer to reflective practice were more emotionally exhausted, or reported being more emotionally exhausted at the end of 18 months than did their colleagues who had been working longer. And that to us makes sense too, because reflective practice, like I said, you don't get it overnight. It's an ongoing long-term process, and when it's new to you, you're adding in the stressor of something being new, and you're trying to learn your job with all the paperwork and and the traveling and building relationships with your families, and then you add that into, now I also have to learn a new way of being supervised. It wasn't surprising to us that they reported greater levels, that newer employees reported greater levels of emotional exhaustion than those who had been practicing for 3 to 5 years or more. All right, I'm surprised I don't have any questions, but I'll keep going. So also in the quantitative results, so the burnout inventory, as I mentioned, it has those 3 subscales: emotional exhaustion, depersonalization, and personal accomplishment. This is, of the 3 surveys that we used, the Working Alliance Inventory, the Kentucky Inventory of Mindfulness, and the Maslow. The Maslow is the only one that has norms or standardized scores for different levels or different professions within the world. So that she has norms for teaching, teaching college level or post-secondary ed, social services, medicine, and mental health, and then there was an other group as well. When compared, so we looked at the data that home visitors and supervisors provided to us on the 3 different subscales and compared those scores to the norms for social service workers. And what we found is that home visitors scored high on emotional exhaustion compared to the norm. For social service workers, average on depersonalization and low on personal accomplishment for over all 3 data collection points. So we beginning it was more than 18 months ago, about 2 years ago, in the middle, and then at the end, we had people complete the maze lock 3 times, a minimum of 3 times, and we looked at all home visitors' scores. And so they were high on emotional exhaustion, low on personal accomplishment, which is not what you would like to see. Ideally, you would want to see low on emotional exhaustion, high on personal accomplishment. So on those data, let me talk about the supervisors first, and then I'll make my statement. So the supervisors, we also compared their scores to the norms for social service workers and found that they scored average on emotional exhaustion and depersonalization, but they also scored low on personal achievement. So it should be accomplishment. And so if I had just looked at these quantitative data, I would have said, you better gear up for a lot of quitting, because these people are reporting levels of burnout that are high, and they're not feeling very efficacious in their personal accomplishment. So what's sort of amazing, and what one of the things that we think we are writing up right now is that clearly the qualitative data, your interview data said, I can't do this work without reflective practice. I need this time. So clearly you work with a level of burnout, but the reflective practice mitigates that level, so you can say I'm emotionally exhausted, but I keep doing this work. So to me, it really says if you didn't have reflective practice, you'd be facing large levels of not only burnout, but turnover. So another qualitative finding, in order for me to share it with you, I need to remind you about the Working Alliance. So we used the short and revised. It was a 12-item survey that really looked at the relationship between the bond between the supervisor and the supervisee, the degree of agreement between those 2 people on work-related tasks. So did they see their work, the work of the home visitor and the work of the supervisor, did they see it similarly? Were their roles defined? And then was there agreement between the supervisee and supervisor about the goals of the work, what needed to get done? So we looked at that, and what we found here is that, I'm going to read this right off the slide, and then I'll use Ann Bailey language to tell you again. But home visitor scores on the personal accomplishment subscale of the MASLOC and their Working Alliance inventory score at time 3, so at the very end of the evaluation. The greater the sense of personal accomplishment, the greater the perceived working alliance between the home visitor and the supervisor. So here's the Ann Bailey speak. If you think that you have a good, the home visitor and the supervisor say, yeah, I have good working relationship between each other, it's a good thing, that people who reported good working relationships with their supervisor or supervisee also felt higher levels of personal accomplishment in their work, that I'm doing better at my job. And that some of that is a function of the relationship I have with my supervisor or with my supervisees. So I find that one to be very, I'm just happy to see that. I think it tells a lot about the work that you all do and the importance of relationship building. So I'm going to start I'll go through the summary of the findings and then the recommendations that we made, and you'll also see these findings, the summary and the recommendations in the report that Jill mentioned will be sent out next week. So I gave you a whole lot of information, and I've been talking straight for at least 45 minutes, which my family would tell you is nothing new. And so what? What does this matter? What do all these data mean for you? So here's the kind of fancy way of saying it. I'm not going to read all the slides, but basically what we found is that Minnesota is doing a very good job of building a sustainable infrastructure for the use of reflective practice within the MCV program. So there are absolutely some places to improve, but overall, things are well on their way. Home visitors are clearly transferring what they're learning about reflective practice and to their work with families, and that there is a lot of similarity, like I said, between infant mental health consultants, what the infant mental health consultants, supervisors, and supervisees said about knowledge, skills, and burnout. It's very clear to us that reflective practice, as I said, mitigates the effect of burnout for both supervisors and home visitors, and that everybody loves the infant mental health consultant. I put appreciates, but it was very clear to us in the interviews, I couldn't live without the infant mental health consultant. I depend on that person greatly, and that came from everybody. We didn't ask the administrators, but the infant mental health consultants very much felt appreciated as well. So that was very clear to us. So here are some recommendations we made. And again, these are recommendations. We can't say you have to do this, but what we said was that there needs to be some tiered intervention model of training, that based on the data, whether it was quantitative or qualitative, people need more ongoing training. Everybody identified more information about infant mental health and specifically adult mental health, that was a huge concern within the field, and that the infant mental health consultant was great about helping people learn more about adult mental health, but that they were interested in even additional training on that. That looking at having foundational level 2 and level 3 training, so that you would have different levels of training available for different staff at different times. So the foundational would be available, as I mentioned earlier, for new staff coming in, so they wouldn't have to wait until the model provides the training. They would have some basic information provided to them as part of initial training once a person starts the job, but that for those who have been doing it a long time, there are many supervisors and home visitors that say, I want more information. Like, I've been doing this a long time, and we think we do it quite well. Like, but what's new? We want to hear what's new in the field of research, and how could it support our continued use of reflective practice? So we're recommending different levels of training be available, and then we also are recommending use of an observation tool. So at the beginning, when we first rolled this evaluation out, we had included this. We took it out, but we are recommending it be put back in now, using the reflective interaction observation scale, because all of the data that we have are self-report, right? So how do we know that people are actually using reflective practice in practice? They're telling us they are, they're telling us they know it, what skills they have, but how do we really know? Having an objective observation scale would really support whether it's being used, reflective practice is being used appropriately in the appropriate situations with the appropriate people at the appropriate times. So we recommend kind of the next step is thinking about using an observation tool. We did recommend that, based on what we heard, that a reflective practice group for supervisors be started, and that people get more support using technology to provide reflective practice, whether that's more support using a webinar system like WebEx or Skype or other ways, especially for those who are in rural areas, to get the benefits of reflective practice without having to make extra efforts to do that. Finally, we recommended that as best they can in terms of funding, that the infant mental health consultants stay with the agencies, work with the case conferencing, work with individual supervisors, because they clearly are providing a level of support and content knowledge that are not being gained other places. All right, I'm going to look, I have one question, let's see. Did you look at rural metro home visitor response breakdown in the experience findings on the emotional, sorry, 1 minute. Exhaustion question. Was there improvement in the level of acceptance, embracing of reflective practice pre and post study among home visitors and supervisors, especially among those who were initially reluctant or resistant? good questions. We did not look at that mainly because it would have entailed looking at tracking individuals and analyzing. We still could go back and do that, but one of the things, because it was not a specific research question or evaluation question, we did not do it. We could, but it would mean really analyzing individual people's interviews pre and post to see. The other thing is I do think there's some socially desirable responses that we got, right? Because even though we're not MDH staff, we were away from, in a different building, and people knew that we were at part of the University of Minnesota, and we did guarantee confidentiality. There's still a level of who wants to say, I hate reflective practice. Like, I don't want to share my emotions. It's not comfortable for me. Like, this stinks. Nobody's going to say that. So I don't know that we could have honestly looked for that and felt good about the findings, but that's a really good question. If there are other questions, please let me know. I want to share the thing that, one of the things, we're excited about a lot of these data, but one of the things that is probably most exciting to us is a conceptual framework that we developed that does not currently exist within the reflective practice research world. Based on the data that you gave to us, is that we developed a theory of change, or this conceptual framework, that there are different types of ways that, different ways in which people go about the use of reflective practice and thinking about how they work with families. And this is true for supervisors, home visitors. So across the top, for those of you who can't see it, I'm sorry, it's really pretty, it's colorful. But across the top is the theoretical approach. So we termed them the directive approach, the problem-focused approach, and the reflective approach. Then we talked about the nature of the relationship between the supervisor, interventionist, and client. We hypothesized a change process, and then talked about an implementation strategy. So for existence, if you're taking a directive approach, the supervisor is seen as the expert, the interventionist is seen as an expert, and then the client, so that's the family in this situation, is their own circle. There's no overlap between them. The directive approach is very task-oriented. Here's what we're going to do. Here's how it's going to work, and here's what you need to do. And the implementation strategy is prescriptive. I'm the expert in this situation. I know how to work with babies. Here's what you should do. So another way is problem-focused. And in a problem-focused approach, the supervisor is seen more as a mentor. The interventionist is a mentor. And the case consultation with peers also is part of that interaction between supervisor and home visitor. But the client still stands alone. So they're yet to be part of the process in the problem-focused approach. The problem-focused approach tends to have a solution-oriented change process. So have you tried this? What about this? And then, so you're searching for what to try. So you're looking for solutions to problems. On the far right is the reflective approach. And here is where the supervisor is a reflective partner. There's a facilitated case consultation. The interventionist is the partner, and the client is also part of the, there's overlap between the interventionist, the client, and there's a partnership there. The hypothesized change process is that there's a partnership with the family, and the focus is on the baby, and a lot of using the term I wonder instead of being a solution or a task-oriented approach. And the implementation strategy is to find the meaning and the cause of the behaviors to support new perspective and processes. So, and what we, based on the data that we had, what we are saying is people ebb and flow through these different approaches at any given time in any given situation. It's not that you get to reflective and stay there. There are times and situations where you need to have a problem-focused approach. And so you would use that model in that time, but hopefully work towards getting back to a reflective approach. What we don't want in this situation necessarily is an overall directive approach. So this is what we're currently writing up, and hoping to publish soon, because this is not, like as I mentioned, there's not a whole lot of research on reflective practice to begin with, and this currently does not exist. It does now because we've copyrighted it, but this is it. So this is our, beyond trying to help you do reflective practice better and giving you your data back to share with your clients, to share with your county boards, your administrators, we also hope to give this theory of change as part of the research that you can use in your practice. So let's see. Yay, another question. The exhaustion question, rural metro breakdown. For the emotional exhaustion question is a separate question. Oh, did you break down the exhaustion question between rural and metro within the experience pools? No, we did not. We looked specifically at between rural and metro, and then experience levels less than 1 to 2 years, 3 to 5 years or more. So we did not stratify again on rural, metro, plus years of experience. Good question. Again, these are things we could do because we have all these data, but really the data, for a good chunk of time, we spent a lot of time analyzing the interview data, and we're still analyzing the interview data, and we could analyze those interview data for years because it's, as I said, it's very rich. You told us a lot of amazing things about your work. So we're currently in the process of writing up a couple of different journal articles, which we will share once we get word that they can be published, and we will share those. But if you have any other questions about the data or this PowerPoint or the report, here, let me put my email address in the chat function. And I'll put my phone number too. If you want to call me, feel free to do that. My colleague Karen, who many of you talked to, she retired in December. Quite upset with her. But she's still around, thank God, having lunch with her today. So, but she also, I can still ask her questions if I need to, and Christopher is still working on this as well. So, but if you want to use me as the primary contact, that'd be great, and I can take your questions to other people if I need to. So let's open up the phone lines. I'm going to unmute you all, so if you have things going on in the background, you can mute yourself, but if you want to ask questions, please do that. Okay, you're all, oh, I'm getting close, wow. You're unmuted, so please ask.
Hi, this is Joan.
Hi, Joan.
This is Joan from Carlton.
Hi, Joan.
Hi, Joan.
Hi. Say, I typed in a question, and what I'm interested in some of the connection between the work that's been done with mindfulness and, you know, increasing your own self-awareness, and I know some of that has come out of MDH. And I'm really interested in that connection between the work that's been happening with mindfulness and with reflective practice. And so I'm just curious if you have any thoughts on that, or I think it could be a really interesting upcoming trainings when we're talking about upcoming trainings to look at those two connections.
Other people here can respond to. I'll just say one of the things that, you know, at the end of any evaluation, there's always a level of, oh, I wish we would have done this differently. I think my colleagues and I would say, oh, we wish we would not have used the Kentucky Inventory of Mindfulness, that there might have been a better measure of mindfulness out there than that one, although that one gets good reviews. But yeah, there really isn't. And so we're not confident in those data, and the data didn't really tell us much of anything. So in terms of the evaluation, we didn't, you clearly noticed, we didn't say a whole lot about mindfulness. But that's certainly on part of the home visiting research world, because Jill and Christopher and I went to the Healthy Families America conference, and it was prevalent there. People were really talking about that. I thought between mindfulness and compassion fatigue, there was a lot of good research being done and good programming being done around that in different parts of the country. I went to a couple of sessions where I was really impressed. Wisconsin's doing some interesting things. And I went to an interesting presentation from Tennessee as well. So there's information out there, but our findings, we didn't find a whole lot in terms of mindfulness, unfortunately.
And this is Jill. I just wanted to add, too, that I think the idea of training really makes sense in mindfulness, especially when we think about the parallel to the parent-child relationship and how important co-regulation is. And then we bring that to any kind of reflective space where we're really thinking about, the groups are spending a lot of time thinking about how they're helping each other regulate and stay calm and keep in a more mindful stance while they're even doing a case conference. So that is so much a part of our work, and that's really become very clear as we've done this project, that that's much of the work of the infant mental health consultant and the supervisor and the home visitor with the parent. They're all thinking about that, and the whole research around the interpersonal neurobiology is so helpful to kind of use that as a frame. So that would be just a great area to move forward into in terms of training and further evaluation.
Yeah. Great. Thank you, Jill. Thank you.
What other questions are out there? Or does everybody just want these extra 25 minutes to do more paperwork?
Hi, this is Daniel from
Hi, Daniel.
County. Hi. I'm curious if anybody from MDH can talk about what the level of ongoing support is likely to be for reflective practice in this whole effort beyond MCV, because I don't know, MCV is such a political, it could be influenced by the upcoming election and other things. So I'm just wondering from MDH if what they can say about a level of commitment, both to training and to funding to support it, not just within home visiting, but or this particular model, but beyond in any home visiting setting.
Yeah, we knew this question would come up. It's a really good question. It's something that's very important to be thinking about. Probably everybody on the call knows that I'm leaving. My last day is next Tuesday. Bill speaking, by the way. So we do, there's a lot of thinking about that going on. How is this going to proceed, and how will we make sure this continues to be a focus? And my sense is that the use of reflective practice, the support for reflective practice is very much a priority, and that the folks here at MDH will be looking carefully at what makes most sense in terms of making sure that priority continues to be addressed.
So I'll just add one piece. Jill, you did nice job. We've had lots of conversations about this, so she reflected those conversations. One of the other pieces is I think that we're looking at ways of making sure that we incorporate it into ongoing funding streams. So you'll see enhanced kinds of activities related to that in the MCV and the RFPs, that if we do anything in the future related to MCV, we'll see expansion in that. Certainly the new nurse-family partnership RFP that just got posted today is also looking at reflective practice. We certainly see an increased interest in that at the federal level, and so I think that will be reflected in the work that we do. As Jill mentioned with her leaving, and we're so sad about that, and it will be a big hole, but we are looking at ways as to what it is that we can do in that area and how best to meet the need, because the need has changed over time. And so how is it that we really address that need? But as Jill said, it is a priority area.
Thank you. I really appreciate that.
I'm going to start singing the blues here. What other questions do you have?
Thanks. I really appreciate that that response from MDH.
Great. Thanks, Daniel. Others? Are there other questions?
If not, this is Jill. I'd just like to make a few parting reflections, if you would bear with me and let me do that. This project has been such an amazing learning process, and there were quite a few surprises along the way as we did this. And I just wanted to mention a couple of those surprises that happened that I think made this project especially interesting.
Muted.
Okay. One of the surprises was that we, initially when we were writing this grant, we were thinking that MDH would be providing the infant mental health consultation to the sites across the state. And it became very clear early on that that wasn't really a very sustainable model to have anyone come from the metro and drive around the state to provide that. But we also, at the time of writing the grant, didn't realize the resources that might be available outstate. And so we did sort of simultaneously with getting this grant, we did a survey of mental health providers around the state who, and asked them what was their capacity and interest in providing this kind of consultation. Thank you, Michelle Fallon. And that information was so helpful to us because then we had a list of people who lived in various parts of the state. And we also, just by some stroke of incredible fortune, the timing was such that we were starting to look for local resources in infant mental health right around the time a large cohort was finishing up the certificate program at the University of Minnesota, the Infant and Early Childhood Mental Health Certificate. And so we were able to sort of connect with some of those new resources in the communities, and so the MDH role of in this whole process really shifted from providing the consultation to the sites to actually supporting and mentoring the consultants who were providing that consultation. So that was, it was kind of puzzling because we were creating our evaluation, and this was changing as we were going, so it was like a lot of moving parts happening at the same time. But it was also an incredibly validating thing that happened, and it seems very clear that our focus on system building and promoting resources at the local level, there was just a lot of wisdom in that, and now we have this cohort of folks out there in the state who have been providing really high quality infant mental health consultation to home visitors and supervisors, focused not only on infant mental health consultation, but also promoting capacity and reflective practice. So that's been a kind of a really exciting shift. The other thing that's very similar to that is that our initial hope and expectation was that we would provide this consultation to supervisors to get them sort of to a new place in terms of having received reflective consultation themselves, and then therefore kind of having gained this capacity to provide the reflective supervision to the home visitors. And we were thinking of it as sort of a short-term intervention that would, you know, we do it for 18 months and then we sort of pull out. And it's very clear from all the evaluation that we've gotten, all the comments at all levels, that this kind of support really needs to be something that's ongoing and sustained. That this kind of support is something that you can see by the all of the evaluation, the comments of the staff and the supervisors, how important it's been for them to have this kind of support that's predictable, reliable, and available to them over time. And I think one of the things that's really unique about the way we set this up was from the very beginning we knew that supervisors were asked to provide reflective supervision, but given very little training in how to do that. And so we knew that providing a reflective space for the supervisors would be really important, for them to have a space where they're thinking about their own professional development, their own growing capacity to be a co-regulator and a reflector, a collaborator with their staff, which is a very different model than most supervisors were ever given supervision themselves. So I think that I think of all the things that I'm proud of, the work that we did, I think that's one of the most proud pieces for me, that we were able to really build in that support, and now we see how effective it is and how important it is.
I do have one other question.
Yes, and then we're done.
Yep, okay. So the question was there a difference between home visitors' years of experience as a home visitor regarding burnout levels? We found nothing there. There were no differences in burnout levels based on years of experience. We looked at a lot of different demographic questions, years of experience, education levels, things like that, and the only one, the findings that we shared were the findings that we found, which made them findings. So like I said, we do feel we're very confident in saying that had we gathered data for another maybe 18 months, we would have seen the differences we expected, but reflective practice, true implementation with fidelity takes time. So. Any other questions, comments?
I just wanted to add, too, this is Jill again. The initial evaluation was supposed to be for 3 years. It was supposed to be a 3-year, and it took that long for us to be able to get up and going with all the delays at the beginning. So in some ways, I wish we could do it all over again.
Oh,
and do it for a longer period of time and see what it would be. But it was a start, right?
Even given those obstacles, we still found really interesting and amazing information about what's going on here in Minnesota when it comes to the use of reflective practice. And overall, it's really good. So you all should feel good about the data that were shared today. And again, I just thank you for participating. It really was appreciated, and none of this would have, I couldn't have done this without all of you and your time, so thank you.
Thanks very much, Anne, and thank you all for being here in the room with us, and for all of you out there. Thanks again for all your hard work, and hopefully we'll have lots more evaluations in the future of this kind of thing. Thanks a lot.
Bye.